Good afternoon, everyone. We're going to go ahead and start a new module this afternoon. Now remember, your exam 1 is just on psych. Exam 1 is just on psych. Module E starts a whole new process for exam number 2. So as we're beginning, realize that we are looking at now material for exam number 2. Today we're going to be talking about GU and renal alterations more. And today we're going to focus on urinary blockages and blockages throughout the urinary system. Your reading is from your Med-Surg book, the 7th edition of E GU, chapter 69. I would definitely read through that chapter. I also recommend that you go to the library website and then go to the Nursing Reference Center. Here are 4 different quick look type things, if you will. It's kind of quick, down and dirty, covering most of the information that we're going to be covering today, because we're going to be talking mainly about urinary tract stones, kidney stones, erythrolithiasis, whatever you want to call them, renal calculi. But that's what we're going to be looking at. And these 4 have some different types of information that I highly encourage you to read to help increase your understanding of the whole process. So right now I want you to just kind of relax. This is where you really want to be. Okay? You want to be there on the beach, nice and calm. Just think about listening to those waves coming in. This is a photo I took when we lived in Hawaii. But I want you to just kind of think about that, because you get in that relaxed mood, because what we're going to be talking about now is pain, agony, and misery, because that's what urinary stones, renal calculi, do to your patients. Your patients will come in complaining of the worst pain they've ever had in their lives. Women tell me that the pain is worse with a kidney stone than it is having a child. That it is just absolutely unbearable. And once you see a patient come to your emergency department with a urinary stone, with a renal calculi, you'll not forget that. You'll see that again. These people are just raving in pain. They're bent over. They can't get comfortable. They can't sit down. They can't stand up. They can't move here. They can't move there. They're just in excruciating type pain. And as you can see by looking at these calculi, they come in different sizes, different shapes, different types of composition, and we'll talk about the compositions of the stones. Many times when we see like this one under agony, those points are very sharp. And as that begins to move down the ureter, making its way out of the kidney into the bladder, it's basically hitting the sides of that ureter. And every time it hits the side of that ureter, it's causing pain. It'll also be causing, a lot of time, bleeding. So those are some of the things that as we go through. And there are different types of kidney stones, and we'll talk about compositions of those stones. So think about it as you look at this. Your patients are going to be very, very uncomfortable as we go through this. When we look at urolithiasis, let's get some terms straight. Urolithiasis. Lithiasis actually means the formation of the stone. Calculi is the actual stone itself, or calculus. It's the actual stone if you look at and you're doing your reading. But lithiasis is actually the formation of that stone from the chemical composites that will make it up. But we see about 500,000 people per year with kidney stones. When we look, there's about, get my page right here. When we look, there's a large number of those that have to be hospitalized just to get the pain medication or to get the treatment to relieve that stone and those type things. Average ages that we see for patients with kidney stones, typically between ages 20 and 55. I can't really give you a good reason for that. None of the books said anything about why they think that age range is more prevalent. May have a lot to do with diet and with exercise and those type things. When we look at the United States, the Southeast leads the way again, unfortunately. Okay, majority of the stones that we see in the U.S., the Southeast has the highest prevalence of stones, then the Southwest, and then goes to the Midwest. When we look worldwide, the U.S. is the leading country for kidney stones. Japan follows close by, and then Western Europe. Gentlemen, we lead the way in this one. Most kidney stones, men tend to have more kidney stones than women. Now, there is one type of stone that's called a Sturvite stone, and women are 3 to 4 more times likely to have that type stone than men are. And as we begin to go over and look at some of the etiologies of stones, you'll see why that is. Caucasians typically have a greater number of kidney stones than do African Americans. And it tends to run in families. If a family member has had a kidney stone, there's a greater likelihood that someone else in that family will also have a kidney stone. So those are some of the things to think about when you start doing your history on these patients and start getting your assessment of these patients. Also, if you've had a stone in the past, guess what? You're very likely to have another one. 50% of the people who have had one stone will have multiple stones. They'll have to go through this process more than one time. So that is one of the things that we really, as we move toward the end and we start teaching our patients, some of the things we want to be teaching our patients are means to prevent that formation of those stones. So we want to, with that population, if you've had a stone, you know you may get it again. Let's do everything we can to prevent that from occurring again. And that's part of our teaching process that we'll be doing with our patients. So when we look at urolithiasis, or the formation of stones, okay, there's several causes that we see that can lead to these formation of stones. There are metabolic reasons. There are dietary reasons. Genetics. We kind of talked a little bit about that a while ago, but there's some specific genetic disorders that actually lead to that as well. Climactic, different climates. If you looked, when we're talking about the U.S., we looked at the southeast and the southwest. What do those have in common? Heat. Hot summers, a lot of heat with those type of things. So we see a lot of problems with that. Lifestyles play a role as well. Occupational can play some roles. I never could really get a good type of occupation in looking at any of my research, but we'll go back to some of the other things. Someone who has frequent urinary tract infections also has a greater instance of urinary stones. And then urinary stasis. In other words, you're not able to void that urine from the bladder. That urine is building up in the bladder and is staying there. Urinary stasis can lead to those problems. Now let's look a little bit at these a little bit more individually as we go through. There are some metabolic disorders that you should know about. If you'll look in your IGI, or when you get home look in your IGI, table 69-5 basically says metabolic defects that commonly cause calculi. Those are some of the things that we'll see. Hypercalcemia, primary hypercalcemia. Basically, there's absorptive increase in intestinal calcium. In other words, the body's reabsorbing that calcium, absorbing the calcium from your diet. And because of that increased absorption of calcium, the kidneys now have to get rid of it. And as the kidneys begin to get rid of the calcium, now you've got an overabundance or a saturation of calcium in the urine. And so it leads to can lead to stone formation. Now there's also secondary hypercalcemia, and again, that has to do with hyperparathyroidism and vitamin D. So if we know that someone has a history of hyperparathyroidism, then we really need to be watching them because they're at increased risk of developing urinary calculi. Hyperoxaluria. That's hard to say. Again, there's primary and secondary causes. But that is also a genetic. When we talked about genetics, when we look at metabolic, it's genetic and metabolic. But basically, it's an autosomal recessive type trait which ends up in producing high levels of oxalate. When we look at kidney stones are primarily made of calcium, oxalate, or uric acid, or the stearvite, and we'll talk about those a little bit more. But we look at those major type things. So if we see these genetic type issues, then we know, and if we get somebody in that's having multiple stones, continuous having stones, we may need to do a genetic workup on these patients to find out, is there a genetic reason for the formation of these stones. Secondary increased oxalate problems comes back to dietary. Excessive foods that have oxalate in them, those are foods such as your very dark vegetables, your spinach, your turnip greens, rhubarbs, those type things, beets. They also talk about peanuts, okra, chocolate, and lime peels. You know, all the good stuff. Chocolate, I mean, come on. I can't do without my chocolate. Okay? And then there's hyperuricemia. Hyperuricemia. What disease process is hyperuremia? Hyperuricemia. How about swelling and redness of the big toe? Gout, okay? So that hyperformation of uric acid, okay, can lead to stones. But again, part of the stones can be, part of the composition of stones can be uric acid. So if we have someone that has that overproduction, the gout type, the patient that's gout, especially if they're having frequent flares of the gout, you need to be aware that that puts them at a greater risk of developing a urinary calculi. So we need to make sure that we're teaching them about those type processes. The Sturvites, basically the Sturvite stones are made of magnesium ammonium phosphate. Okay, I'm not going to ask you guys what are these stones, what are the chemical compositions of these stones, but you need to have a decent idea. And typically a lot of times this is related to frequent urinary tract infections, because the frequent urinary tract infections can actually cause more breakdown of some of the materials, changes the acidity of the urine, which leads to more stone formation. Urinary tract infections with Proteus, Klebsiella, Pseudomonas basically increases the pH of the urine. So if I'm increasing the pH, is it more acid or more basic? I'm increasing the pH, am I increasing the acidity or the alkalinity of the urine? The alkalinity, because it's becoming more basic. So, and think about who tends to have more urinary tract infections, men or women? Women. So now you can see this process. We said that women have the Sturvite type stones 3 to 4 times more frequent than men. So we're seeing this frequency of urinary tract infections can lead into those types of problems. So those are some of the things that we want to look at. There's something called cystinuria. Again, this is a genetic type process that really will cause a change in the metabolism and increased production of cysteine, which again is a component of the urinary stones. Okay, make sure we went over that. When we look at the formation of these stones, typically what we're seeing is basically an oversaturation or a supersaturation of the urine with that chemical, whether it be the calcium phosphate, the calcium oxalate, the magnesium ammonia phosphates that go along with the stearites, the cysteine, all of those. For some reason, we're getting an extreme concentration. And as that concentration increases, it's less likely that the kidney can excrete them. So you're getting all that formation of that chemical there together, and it begins to clump together. As it clumps together, that stone begins to form. And if that stone forms, it continues to grow. You think about, it starts out just as a small granule, and then it just continues to grow and grow and grow till it gets large enough that either it can't pass, or it's large enough as it does pass, it begins to cause lots of pain. Okay? And we'll show you some stones that are actually called staghorns that actually form inside the kidney, and it's one huge stone that actually takes over the whole kidney. So those are some of the things. But we really want to make sure, and this will go in some of the teaching we talk about, that we need to make sure our patients are drinking plenty of water, staying hydrated, those type of things. And also talk about those urinary tract infections, preventing urinary tract infections in the patients. The acidity of the urine will also play a role as well. Certain drinks will acidify the urine more, certain drinks will alkalize the urine more. So we need to keep kind of a normal pH balance of that urine to prevent some of these, because There are some stones that form better in acidic situations. Some stones form better in alkalinic situations. So we need a good balance when we begin to look at those type issues. Okay. Now, as we look at climactic, what do you think when we look at that climate? How's the climate going to affect this whole process? Absolutely, dehydration. And with that dehydration, what's going to happen to the urine? It's going to concentrate. And if the urine's concentrating, what's going to happen to all that chemical that's in the urine? It's going to be hyperconcentrated too. So we need to make sure, again, that's why the southeast and the southwest tend to have higher concentrations of stones. We tend not to drink enough. We tend to get dehydrated too easily. So that's some of the things that we need to work about. Dietary, when we go along that same way, let's look at the South. What are some of the foods we love to eat? Fried, okay. We tend to eat a lot of fried foods. We tend to drink a lot of sodas, a lot of sweet teas. All of those actually have caffeine in them, which is actually going to dehydrate you more. Also increases the risk of stones, okay. We tend to eat, I don't know about you guys, but I tend to eat a lot of green leafy vegetables. I like green leafy vegetables. Those are high in those calciums. We also tend to drink more dairy products, eat cheeses. So again, high in those calcium type levels. So diet definitely plays a role into those type things. Lifestyle can also play a role. Sedentary type lifestyles. If we're up moving, what's going to happen to the calcium in the bones? Okay, we're going to be making sure that our bones are going to get more dense, so we're not going to have as much calcium in the bloodstream. That's going to be reabsorbed into the bones to strengthen our bones. So that's with that exercise. So if we're not exercising and it's being just there in this urine, being excreted, not getting to the bones where it needs to be, greater formation, greater concentration of calcium in those urinary systems. So those are some of the big things that we look at. Occupational, the big things I could find reading about occupational, let's think about some of the jobs, okay? Let's say that you work in a foundry, okay? Someplace like American Cast Iron and Pipe Company in Birmingham, where you're working around molten metals, those type of things. What kind of problems are you going to see from that? Dehydration, the heat, the dehydration if you're not drinking enough. What if you're out mowing grass all summer long, okay? You're working as a carpenter, you're working as someone that's working outside a lot. If you're not hydrating enough, those type of things. But then about those office workers who are just sitting around all day long, never exercising, not eating correctly, those type of things. Again, that sedentary type lifestyle plays in. So that's where I could find a lot of those issues when we talked about occupational as we go along. I don't know that you can see that on the screen up there, but these are the different types of stones, okay? The different types of stones. And it gives you a breakdown of which one are more prevalent. The calcium oxalate stone is probably the most prevalent. Typically, they're small in size, but they can get trapped in the ureter. So they are more frequent in men than women. About 35 to 40% of all stones are made of calcium oxalate. Typically, what causes them is that idiopathic hypercalciuria, the increased amount of oxalates, okay, and then family history. Those are the ones that tend to run more. So what are we going to do for these? And we'll talk about that a little bit more as we get over to treatment and everything. But we've got to increase the dietary, increase the hydration on these patients. The calcium phosphate stones, again, they can be mixed with oxalates. They can be mixed with the styrates. So the oxalate stone or phosphate stones typically aren't a true one compound type stone. They're only about 8 to 10% of the stones that we see. The styrite stones we talked about, more prevalent in women, 3 to 4 more times common in women, and again, usually related back to recurrent urinary tract infections for those patients. The uric acid, again, the people who have gout, the high uric acid levels, Again, only 5 to 8% tend to have those type stones. And then the cystine, which is that genetic type problem, it's a recessive trait. What we see is it tends to be a high acidity of the urine, but only 1 to 2% of the population with stones tend to have that one. So you can see that calcium oxalate probably is the most prevalent. Now, how do I know what type of stone my patient has? How do I know what composition it is? You have to catch the stone. That's it. One of the things that you'll be doing with a patient who has a urinary calculi or a kidney stone is you're going to have them strain their urine. When they come into you to your emergency department, one of the things you'll have them do once you get their pain controlled, once you start hydrating them, is you want to strain their urine. Typically, there are different types of strainers that out there. When I first started, we just went to the hospital, just went to the hardware store, bought paint strainers, and that's what we used. There's hard plastic ones now. There's several different type of things. At home, a coffee filter will work real well to strain the urine to look for stones. Once that stone is captured, then it's sent off to the lab to be analyzed for its composition. Once we know that composition of that stone, then we can work up a treatment plan for that patient based on the composition of that stone, and then help them do what's best to prevent that stone from happening in the future. So one of the jobs that you will have as a nurse is making sure that that patient is straining that urine. Okay, that'll again be part of your teaching plan that you'll be doing toward these patients. So what are some of the clinical manifestations? Clinical manifestations of kidney stones. Well, what's the one we talked about most prevalent? Pain. Okay? Pain. They're going to say it hurts. They're going to be bent over. Typically, where is that pain going to be located? Typically in the flank areas, okay? Sometimes as the stone moves, every time that stone moves, they're going to have an increase in that pain. Men will have pain down in the testicular region as well as that stone moves toward the lower area. Women can typically have pain in the labial area as that stone begins to move down toward the bladder. One of the things you want to do is track this pain. Yes, ma'am. For those who are online listening right now, her question is, do you have to have actual visual evidence that there's a stone there before you medicate for pain? The answer typically is no. I mean, you're going to treat basically on signs and symptoms. You're going to treat that patient. Now, you can never say never in any situation, but there are drug seekers that know, hey, this is what it is. But then you're going to base that on the history, how many times that patient been in with this type process. You're going to try to get a urine, and we'll talk about some of the other things that we'll see as far as signs and symptoms in some of the labs that we do. But if they're in severe pain, believe me, you will know someone who has a stone versus someone who is faking. It is pretty easy to tell. Typically, they're going to have this pain. What kind of questions are you going to ask about the pain? I hear mumbling. Somebody speak out loudly. Where it's at. Location. Huh? Describe the pain. Okay. Yeah. What makes it better? What makes it worse? Severity. Okay. On a 1 to 10 scale. Okay. All of those are things you're going to be asking about. What's the intensity? What's the location? What's the duration? When did it begin? How long has it been going on? Okay. Anything make it better? Make it worse? Are there any associated symptoms going along with this pain? Such as nausea, vomiting. Have you been sweating a lot? Okay. So typically these patients, because the pain is so severe, they're going to be very nauseated. They may be vomiting, and they're typically going to be diaphoretic. The other thing you're going to ask about basically is, well, it just went away. I'll come back to it. But when you're looking at those pain-like type levels, location, duration, intensity. Does it radiate? Is it radiating from one area to the other? As we begin to look at chest pain, later on we'll talk about chest pain. but you always got to ask about radiation. Physically, you're going to look at this patient. You're going to typically be able to look at that patient and tell that patient is in pain. Okay? They're pretty much, if they're vomiting, you're going to know that. You're going to observe that. You're going to be able to touch their skin. Are they diaphoretic? Are they cold? Are they clammy? These patients a lot of times will also have fever and chills along with this, because unfortunately these stones many times can lead to infections, urinary tract infections, cystitis, but even more sometimes can lead to pyelonephritis. So you may see some infections in the kidneys as well. If they void, or when they void for you to collect a urine specimen, it's not uncommon to actually see red-colored urine, hematuria, because as that stone begins to move down that ureter, going down through, it's causing damage. So you may see frank blood. You may not. You may only see microscopic hematuria, but you have to get a urine specimen on these patients to be sent to the lab to make sure, to see if there's hematuria there. If I had a patient that had hematuria and I had not had a chance yet to get a X-ray or an ultrasound or a CT scan on this patient, I would definitely treat them right away if I saw that hematuria. I'm telling you, even urinary cystitis and urinary tract infections can cause a lot of pain, so we can sometimes will treat those as well. But these are the major clinical manifestations that you're going to see with these patients: pain, nausea, vomiting, diaphoresis. Again, you want to check their temperature to see if they're running a fever. You're going to get a set of vital signs on these patients. You're going to see what's going on. So what are some of the diagnostic studies that we're going to do on these patients? Typically, the first thing they're going to ask for is a urinalysis on this patient, just a routine urinalysis. What can I tell from that urinalysis? Have you guys been writing down everything when you go to the clinical setting? Have you been looking at the urine and see what types of things you can write down from the urine? Maybe, maybe not. Okay. So the first thing I can see is the specific gravity of the urine. I can see, it'll tell me the color of the urine. It'll tell me the specific gravity of the urine. So I can tell whether that patient's hydrated or not hydrated, correct? I can tell by the color again whether they're hydrated or not hydrated. It'll tell me if there's any red blood cells in the urine, right? And if I see red blood cells, can see hematuria. Go ahead. Absolutely. I'm going to look at white blood cells as well. Is there possibly an infection going on with white blood cells? If you look at your urinalysis next time you're looking at it, it'll also talk about crystals. Are there any crystals showing up? They won't be able to identify on a basic urinalysis, but it may show that they're seeing crystals in the urine. And that's going to tip me off again. Hey, this may be a stone going on because I've got those type things, okay? We're going to look at all of those type issues as we're looking at that urinalysis. That's what that physician is going to look at. We're going to get a complete blood count, okay? Again, we're looking more here for an infection. We're going to be looking more at that white blood cell count. Do I have an infection going on with this patient? We're going to get serum electrolytes. Always good to get a set of electrolytes, especially if I'm thinking about dehydration. I can get that BUN and creatinine. Very important to get as part of that electrolyte study. Why? Say it. I can't hear you. Kidney function. Absolutely. As we look at some of the complications of kidney stones, we can get urine backing up all the way up through the ureter back into the kidney. So we can actually begin to get damage to that kidney. And what are we going to see going up lab-wise if we've got damage to the kidney? Creatinine and BUN creatinine. BUN also will help me know about the fluid status of that patient. So we really need to be looking at those. Why do you think I might want a serum calcium and phosphate and uric acid level? Absolutely. I'll get out here, but she said it here. That's typically what the stones are composed of. Absolutely. I think I heard it from both areas. But that will kind of give me an idea. Do I have a hypercalcemic or a low calcium level to do those things? Typically, the next test they're going to get for these patients is going to be a KUB. Now, here's where you've got to kind of play it by ear. She asked about, do I need to medicate these? Many times, you're not going to be able to get any of these tests, like a urine ultrasound, CT, any of these till you get the pain relieved on that patient, because they can't lay down on that table and be still long enough to get a good x-ray because they're hurting so badly. So it's not uncommon to medicate them so we can get them to relax a little bit till we can get some of these tests. A plain KUB, basically, what's KUB stand for? I heard it louder. Kidney, ureter, and bladder. Absolutely. That's what we're going to look for. There is a KUB. I bet you can pick out the stone on there, correct? This guy's got or lady, I'm not sure which, has a pretty good sized stone right here. Now that's typically what you're going to see on a patient with a KUB. Now, sometimes you may or may not be able to see the stone, okay, because they can be very small. And if that person has a lot of stool, a lot of air in the intestines, you may not be able to see that stone. But that's typically the first test that most of the time they're going to get, is just to see if they can visualize that stone. So if I saw that and saw that patient with that stone, I pretty much know now I've got a kidney stone on this patient. My main things now are to treat the pain. And what do you think the next thing is to treat? I want that person to pass that stone on their own if possible. Fluids, absolutely. We want to hydrate that patient. We probably, if there's no history of congestive heart failure, we're actually going to overhydrate that patient. We're probably going to be bolusing them with normal saline fluids to get them to urinate, to get that pushed on through, if at all possible. So that's kind of one of the things we're looking at. Let me show you some of the other things real quick. This basically is a IV. This was probably an IVP where they did that, or it could be a retrograde pyelogram. But you can see large number of stones here in the bladder. Can you see these? Okay. This patient's just got large numbers of stones, and some very large stones in the bladder as well. But you've got a stone blocking the juncture where the ureter comes into the bladder. And what's happening now is urine is backing up into the ureter. Okay? So that's causing that. Now it's also backing up into the kidney. That's one of the big complications of kidney stones. That's one of the things that we want to try to prevent. That's something that, again, we have to be careful of. And many times if you may be able to see that a little bit on x-ray if the radiologist may be able to see that. But typically you're going to have to do some sort of study where you have dyes involved. Now, stones can basically be anywhere in that system. They can be in the renal calculi. They can be in the collecting ducts. They can be down the ureter. They can be in the bladder. They can also be at the neck of the bladder, and they can be in the urethral area as well. Here is one of the things we talked about earlier called a staghorn calculi. Basically, this whole area here is a stone. Now that's actually going to require open surgery to remove that stone. Probably no other way to really break that one up. Say again, ma'am? They can be various. Typically those may be more the Sturvite type process, but they can be all forms of the stones. CT also, sometimes we'll get a CT on these patients, especially if we're looking at much smaller stones, and we're looking at things the CT may be more pronounced for us. An IVP, what is an IVP? An intravenous pyelogram, okay? So basically what we're doing is we're injecting dye into this patient, and then watching it go through the kidneys. We're seeing it being processed through the kidneys, going from the kidneys down through the ureters to the bladder, and then out through the urethra. So we can see blockages for those. Now, sometimes if we're seeing small areas, okay, we're seeing some things going on from there. We may want to go from the other area and do what's called a retrograde pyelogram. Basically, what you do in that point is typically a urologist taking care of that, so you may be assisting. They're going to use scopes, go inside the bladder, and then actually inject dye back up through that ureter to see how much blockage is there. Okay, if someone has bad kidney disease and we have to worry about the amount of dyes we're giving them, and we don't want to do that, and we want to see where the blockage is, we can use a smaller amount of dye at that point. We're going to try the CT first. We're going to try everything we can to protect the kidneys before we do that, but that's one of the things. And then we talk about stone analysis. We kind of already talked about that a little bit. Once that patient passes that stone, we need to send it off to the lab for analysis for that stone. Questions on any of the diagnostic tests? Yes, ma'am. Her question is, do you insert a scope? Yeah, it's a cystoscope. Again, that's done by the urologist, and they do that. And sometimes these patients may actually have some conscious sedation, those type of things, depend on what's going on with that patient. But yeah, it's a cystoscopic type process. And we're going to talk more about some of those type processes in just a moment. Now, we took a look at the one with the stone, and then basically the major complications that we see from kidney stones, other than the pain, which most patients tell you that's my major complication. You get my pain under control and I'm going to be better, okay? But we can also see that hydronephrosis and that hydrouritis where we've got that blockage back up. That's typically the biggest problem that we see, because if we begin to get urine backing up into the kidney, we begin to get death of that kidney, and that's not a thing that we want to happen. So that's one of the things we really want to prevent, is that. That staghorn calculi, again, if we see those, that's really pretty ominous, because you're stopping the function of the kidneys because of that stone that's there. Typically, if they're that large as the one we saw just a moment ago, that section of the kidneys probably not filtering at that point in time. But we still want to get that out, because portions of that can break off and continue. Also, they will continue to grow if you don't do something about it. You can probably see down here in the lower portion, there's other stones there as well. So this person has a really bad case of stones. So how do we treat these? How do we treat these patients? I tell you what, let me back up. I want to back up to one thing here, okay? Let's talk a little bit about, I think we've kind of talked about this, but I want to make sure I cover this with you. When we get our patients in, especially when, excuse me just a moment. And I think I'm beginning to talk about we talked a little bit about nursing assessment, nursing type things, and we kind of talked a little bit about this. But as you're doing this, you're getting these patients in, part of your role is assessing this patient, as it is with any patient. Assessment, assessment, assessment. You can't make a plan. You can't really do treatment unless you're assessing the patient. So we talked about the assessment of the pain. We talked about that. What other things would you want to know about this patient? Say it again. Type of diet, okay? Especially we talked about dehydration type things. You know, what kind of, do they drink a lot of fluids? Do they drink a lot of sodas? Do they drink a lot of tea? Those type of things. Also, recent diet. If they've been having nausea and vomiting, how long has it been since they've been able to keep anything down? Because at this point they may be dehydrated, and we really need to get fluid started on them to get it going. Absolutely, diet. What else? Family history. Absolutely. Why family history? Because it does tend to run in families. Absolutely. So we want to know, has anybody in your family ever had a kidney stone? Also ask them, have you ever had a stone? Typically, if they've had one in the past, they will tell you, this pain's just like the last time I had a stone, okay? They will tell you that. If they've never had one, you may have to ask, again, you'll ask them, have you ever had a kidney stone? And they'll tell you yes or no on that. What other kind of disease processes do we want to ask them about? UTIs? Have they had current or frequent UTIs? Have they recently had a UTI? I don't know who said that, but from there, okay? What were some? Gout? Do they have a history of gout? Absolutely. And if they have gout, are they on medications for the gout to help reduce that uric acid levels? When was the last time they had a flare up of the gout? What else? Medications. Absolutely, medications. Think about it. What are some of the medications that may keep these patients dehydrated? Diuretics. Absolutely, the diuretics. Are you taking any diuretics? Absolutely. What about lifestyle? Do you exercise, or is it a sedentary type of lifestyle? Remember, all of those can lead to that. As always, we want to ask them about any recent surgeries, okay, as we begin to do. If we're going to do some of the other treatments, we need to be careful. The other thing we'll ask them about, are they on any type of anticoagulants? We need to know, because if we're doing certain procedures, we have to be very careful. We'll need to get an INR, PT, PTT on these patients. So you guys hit the majority of it. Very good. Okay. But also you need to ask them, is there any history of kidney disease? Because if there is a history of kidney disease, or if that patient only has one kidney, which there are a large number of patients out there that just have one kidney, treatment of that stone takes priority, because the last thing we want to do is have that urine start backing up and causing damage to that kidney. And you'll see that as we start talking about the treatments a little bit more. The other thing you may want to ask about, and this is something that we'll talk about in lectures next week, is BPH, benign prostatic hyperplasia or hypertrophy, because those can cause changes in the urine, the flow of the urine, which can cause backup and cause stasis of the urine, which can cause some of the things in men as well. What about hyperthyroidism or hyperparathyroidism? I've got to read my form better. Well, we talked about that parathyroid issue being a problem, so calcium is part of those type things. Generally, on assessment, when you're looking at this patient, your observations of this patient, you're going to be able to see that pain. We talked about that. Check their skin. Check their vital signs. You want to look at their blood pressure. Look at their pulse rate. Are there indications that they are dehydrated? What do you think the pulse rate and the blood pressure is going to be related to the pain? Probably elevated. But again, they may be dehydrated, so we're going to look at some of those as well. We want to check their abdomen, okay? Unfortunately, an inflamed diverticulum can actually mimic some of these type pains. Not as severe, but they can have some of these type pains. You want to listen to the bowel as well, because if this pain has been going on long enough, some of these things have been going on, you can actually develop an ileus, a paralytic ileus as part of this. So you want to listen for bowel sounds. You want to check for abdominal distension. Then, of course, we talked about when they void, you want to look at that urine. Is there blood in the urine? And you want to strain all your urine for that patient. Okay. So how do we treat this? How do we treat? Again, the main thing we want to do when these patients first come in is we want to try to control that pain and get that patient hydrated if we can. Now, when we start looking at medical treatment of these patients, what the indications for actually doing something other than letting it pass on its own. I'll get it out in a moment. But basically, typically we want that patient to pass the stone. We don't want to have to do anything if we don't have to. We want to try to control that pain, keep them hydrated, and let them pass the stone by themselves, okay? That is the optimal, but that's not always possible. So indications for medical treatment for these patients would include stones that are too large for spontaneous passage. Now you're saying, how do I know if it's too large for spontaneous passage? That's not your responsibility to know, okay? But just understand that if the physician says, I don't think this stone can pass on its own, then we're probably sending this patient home for more definitive care. We're not going to try to allow them to let it pass on their own. If the stone is associated with bacteria, okay, in other words, there's some sort of infection going on, or this person has a symptomatic infection, we're not going to wait for them to pass that stone. We're going to send them home for definitive treatment at that point in time. If that stone is causing any type of impaired renal function, we've got that backup of fluid into the ureter and back into the kidney. It's time to do something for that patient because it's not going to pass on its own. We've got to get that stone out of there. If we can't control that pain for that patient, we've given them morphine after morphine, maybe even gone up some Dilaudid. I have seen patients that we've had to use Dilaudid on to control the pain for these kidney stones, okay? But we've given them the dosage. They're groggy. You're getting close to that respiratory problem you're worried about, and they're still complaining of pain. it's time to move them on to do some other definitive treatment for that patient. If we're unable to treat this patient medically, in other words, we can't take the risk of them passing the stone on their own. There's some other things going on. We can't really hydrate them because of the congestive heart failure or something like that. Then they'll go ahead and send them on for definitive treatment. And then any patient that has a history of one kidney and there's chance of a kidney stone, they're not going to wait for that stone to pass on its own. They're going to send that patient on for definitive treatment to make sure we'll get that stone out of the way, because the last thing we want to do, again, is cause damage to that stone or to that kidney if at all possible. Now, there are several types of treatments that we're going to look at as far as caring for these patients. Lithotripsy is probably the treatment of choice. The extracorporeal shock wave lithotripsy, or ESWP, is actually the treatment of choice. And it's the treatment of choice because it is non-invasive for these patients. It's non-invasive. What happens is, I put up some videos for you guys to look at. I hope you've had a chance to look at it. There's one demonstrating the lithotripsy. But basically, these patients are placed on a table, and some of the tables, it depends on which type you're using and where you are. Some of them are water-based beds, okay, so that the waves will transfer. Some just have a section that goes over the kidney that's water-based to allow that deflection of the sound waves. But those have to be there to get that going through. These patients typically, get my page here, are going to be placed on that bed. Most of the times they're going to be sedated. A lot of times they will use conscious sedation or even sometimes general anesthesia. And the reason is they have to keep this patient in the correct position to use those sound waves to get to those areas. We can't have that patient turning, moving, those type of things. So you may see those patients being even under general anesthesia or definitely conscious sedation at the least. When these patients have this treatment, some of the things that you're going to talk to them about before they go into the treatment is, of course, what the pre-op is, how it's going to work. When they get through that treatment, some of the things you need to tell them about. You may have some blood in your urine. You may still have to strain your urine, because what this is designed to do is break that stone up into smaller pieces so it can be passed on through. So we're going to want you to continue drinking lots of fluids. We're going to continue to monitor that urine. We're going to continue to actually strain the urine. Sometimes the urologist will actually put in a stent after they've done the lithotripsy. The stent basically is a very small, flexible tube that goes from the bladder up into the collecting area of the kidneys. And what it allows is the urine to flow through, not taking a risk of it actually causing the stones to come through and get stopped up and everything. So sometimes they will put in a stent. If they do, typically that stent stays in place for 2 weeks. They have to come back to see the urologist. The urologist will do a cystoscopic type exam and go in and pull that stent out. The stent, again, will just kind of let the urine flow, let the stones come through without any problems. And it's going to prevent any blockage of that ureter and allow that to coming through. One of the things to tell those patients is they may have bruising near that site, because those sound waves are bouncing off of the skin, so you may see bruising. Any of y'all ever seen one? I've actually never got to see one in progress. You had one? Who had one? Tell us about it, please.
Actually, they took me.
Okay.
Afterwards, I did.
Mm-hmm.
And they did put a stent. I did not have any problems. I didn't have blood in my urine. They don't my thing is, and after they took the stent out, which was way fun. Because they do that in the office. You're wide awake. And they stick the stethoscope in through the wrong way. And they pull it out. And that feels like they're then after they took it out, I passed all from
Okay. Oh, sounds like a wonderful way to spend maybe a summer vacation, right? Yeah. But going back off what she's saying, the people I have talked to have had this, said the stents probably they're just uncomfortable while they're in, and it's no fun for them coming out and everything. And they call that colicky type pain. That's the term that you'll see in the book, is colic pain, because it is from the spasms. And the stones themselves will cause that as they're moving down. Not only do you have the areas touching, but you'll cause the spasms and everything. So, but those are some of the things that you may see. Again, thank you for sharing with us. I appreciate it. Again, I would love to go see one. I've not got to see that. I'd like to go be able to watch that. The percutaneous ultrasonic lithotripsy, that is an invasive type procedure. They actually use a scope. They make a small incision and go in through the scope and actually go into the renal pelvis there, and then are looking for that stone. And then what they do is actually come in contact with the stone with the tip of the ultrasonic, and it actually will break it up at that time. Again, those people, it's again a type of endoscopic surgery. So you can imagine all the things that go along with that. Again, they're typically general or spinal anesthesia with those folks. They don't use it as much anymore because the other lithotripsy, the extracorporeal, actually is so effective. They try not to use it. Sometimes they will if the stones are too large to get down into the ureters. So you may see it used at that point in time. Again, these folks actually may have a nephroscopy tube put in place after this type of procedure to allow the urine to drain out to the outside. So you may have to be doing dressing changes and measuring the urine from the bag at that point in time. These people, again, you still got to strain the urine, check the urine for those type issues. Now, the electrohydraulic lithotripsy, basically, again, it's a cystoscopic type procedure where they go in through the bladder, go up through the ureter, and actually run the tube right up to the stone itself. And then basically it uses ultrasonic waves to break that stone into pieces. They're not looking to break it into smaller pieces as with the ESWP. It really looks at pulverizing it to sandy type things. But the electrohydraulic, they'll do that, and then a lot of times they'll use a basket to pull it out at that point in time. You're still going to have to measure, to strain the urine, to look for stones in those type processes. But these people may notice bleeding when they urinate. For a couple of 3 times after they urinate, they may notice it being bright red as you go through there, because that actually can cause damage to the ureter around it with all the ultrasonic waves and with the baskets and everything going up through there. Typically what happens after they've voided 3-4 times, that urine will kind of turn kind of a smoky color. These patients may have that colicky type pain because of the spasms that are going on and the movement that's going on with that. Typically these patients are put on antibiotics for a couple of weeks after this process. Of course, part of your teaching is to make sure they understand how to take their antibiotics, when to take their antibiotics, and to take those antibiotics until they're all gone. Now, the laser lithotripsy, again, is a procedure with a cystoscopic type where they actually go up through the bladder, up into the ureter. They use what's called I wrote it down. Must be on this page. Okay. They use a holmium laser. Okay. Don't worry about that. Just know that it's a type of laser that basically works very effectively on the stone without causing damage to any of the surrounding tissue. Lasers are interesting devices, but those are one of the things that you will see. It's typically used when there's the stone is down lower in the tract or in the bladder to really break up the larger stones. But again, it is a mildly invasive type procedure that has to be done, and you will take all the precautions and everything that you would need to with any type of invasive procedure. Now, there are surgical type procedures that sometimes have to be done. Remember seeing that staghorn type stone that we see? Those are the ones that are typically going to have that open surgical procedure to remove it. But minimally invasive surgical procedures, or MIS procedures, your book will talk about. That talks about that stenting, putting those stents in to allow the urine to get past that stone, to hopefully allow that stone to pass on its own. The retrograde urethroskopy, again, we've kind of talked about that with all these procedures where we're going in through the bladder, going up into the ureters to look at the stone, to break up the stone. And then the percutaneous we've talked about a little bit, as well as looking at some of the different things. They can use the ultrasound, they can use the laser, any of those through those type processes. Those open procedures, guys, those people typically have a lot of pain from that surgery because of where the incisions are and require a lot of care. Your typical post-op cough, turn, deep breathe. Again, they're going to have nephrostomy tubes in place, so you're going to have to be monitoring the dressing, monitoring the surgical site, monitoring the urine output on these patients as well. So a lot of post-op type care with these patients. Really, when we talk about the medical treatment, the big thing is prevention of infections, protection of kidney function, and prevention of obstruction. I'm not going to really say much about this slide. I put it in there for you because it kind of talks about what they use in the different areas with the different stones for that. Just a couple of pictures of what the shock wave looks like. Again, there are different ones that are out there. Again, the stent, again, you can see it's kind of curled here in the pelvis of the kidney and comes down into the bladder. And a lot of times they'll put it past that stone, again, to allow for the drainage of the urine, so hopefully that stone will come on through at that process. Sometimes they'll actually put that stent in before they do the lithotripsy to allow that urine to drain through and allow everything to drain through from that process. So nursing care, we've talked about the nursing care, we've talked about assessment, pain management. Typically pain management is going to be IV medications. Typically morphine or Dilaudid is what you're going to be using in most of these patients. You may be giving them something for nausea as well with these patients. Definitely hydration. If they can drink orally, we want them to drink orally if they're not having the nausea, vomiting. But most of the time we're going to put in an IV and we're going to be running lots of IV fluids, typically normal saline on these patients. Education is probably one of the biggest things that nurses that we will have to be doing, because we are the ones that are going to see these patients. We're the ones that are going to be discharging them. The physicians will tell them as little as possible and then turn it over to us to take care of that process of educating that patient as to what's going on. Education can focus on from what caused it. They want to know, may want to know what's causing it. But the big things we're going to talk to them about are the things, we've talked about. Hydration, making sure they're keeping hydrated. Okay? Typically, we want these patients to drink at least 3 liters of fluid a day if they're not on a fluid restriction. The goal is to have a total of 2 liters per day of urine output. If they're outside working, that may have to be, but we want to make sure that they're urinating, the urine is clear, and that they're going frequently. We'll talk to them about the diet. Now, we may not know the analysis of the stone when they're first discharged from the hospital or when they're in the hospital. So we may not be able to give them specifics on dietary education at the hospital. That may have to go a little bit later to a consult to a dietitian or a consult back to the office nurse who will take care of those type things. Talk to them about a low-sodium diet. There's been some studies that's shown that a low-sodium diet actually affects the calcium uptake, and so it can help with the stone. So we want to make sure that they're following a low-calcium diet. And we talked about consumption of colas, coffee, tea, because of the dehydration effect of the caffeine. So we want to talk to them about limiting those type processes. I put up 3 nursing diagnoses for you to go over. Guys, as you begin to transition out to being nurses, care planning is something that you're going to have to do, okay? It may be computerized, but you've got to have a plan of care for that patient. And as more regulations are coming in, more is going on in the hospitals with quality improvement, more things are going on, it's going to become more and more on us to make sure we've got to have a plan of care for that patient, and we're following that plan of care. We're going to see more evidence-based practice and more clinical practice guidelines for a lot of these. And to get reimbursement to the hospital is going to require that we follow these through step by step and that we're taking care of that patient. Guys, you do understand that right now, nursing, how nursing gets paid is basically under room and board, right? We're considered room and board at the hospital. We're not paid for our professional expertise. I expect you guys to change that. Okay? That's my soapbox for the day. But you need to make sure that we're out there in the forefront. We need to be paid for what we do, our knowledge base, and then instead of just being part of room and board. Okay? That's what I would love to see this group accomplish. I'm getting toward the end of my career. You're toward the beginning of your career. So this is your charge from me. Change that so you get paid for your worth. Okay? So, off my soapbox. But major things were done, because you look at these, acute pain. Would you not think that is the primary nursing diagnosis for this patient that's coming in to see you? If we can't get that pain under control, it's very difficult for us to do anything else. And go back and review these. I promise you, there's going to be some questions based on your nursing diagnosis, your nursing treatment. Okay? Because that's what we're about, is assessing. Once we assess, we form a plan. We follow that plan through treatment, and we evaluate that plan. That's what nursing is about. Okay? You learned that in your very first semester. And that's what we're looking at. Okay? You have to know the pathophysiology. You have to know all that's going on with it to really make those plans. But again, you need to make sure you understand following that process through. Impaired urinary elimination, looking at those. Be looking at some of those things. What are you going to be doing? Of course you're going to monitor urinary, you're going to monitor I&O. You got to know what the output's like. You need to look at that urine. Does it have an odor, which may indicate an infection? Those are some of the things. Teaching your patient to drink fluids. Teaching them to not pour that urine out and not to go in the commode so you can strain that urine. All of those are part of that urinary elimination type process. Knowledge deficit. These patients are going to have a lot of questions if they've never had a stone before. It is up to you to educate them before they go. 201 right now, which you had last semester, had teaching plans. Pull that back up in your memory banks. How do you set up that teaching plan? You remember, you've got to know, is that patient ready to learn? Are they able to learn? How much time do I have? Do I do it in snippets? Do I have time to do it the whole time? But part of that teaching process as you're going along. You don't have this on your slides that I put up there, but I wanted to make sure that kind of got this up there. There can be blockages in the urinary system anywhere and caused by other things. Kidney stones are typically the biggest problem with blockages in the urinary tract system. But there can be other things. You can actually get blood clots that actually go in here after a stone has come through, or with some of these surgical procedures or these cystoscopic type procedures that can actually block the ureter. You can have cancers that can cause these. There are intrinsic and there are extrinsic. Intrinsic means anything inside the system itself. Of course, extrinsic means anything outside the system. You can see strictures of the ureter from pregnancies, from endometriosis, from strictures from bowels, from strictures, from what am I trying to say? It'll come to me. But any of those things that can compress on that ureter can cause an intrinsic blockage for those. You can have narrowing, and there can be congenital type problems as well that you may have to deal with. When we get down to the bladder, again, the bladder, we can have stones that are causing blockage at the neck, tumors. We can have functional problems such as neurogenic bladder. All of those can cause some of those issues as blockage. Now, next week we'll talk a little bit about some strictures here. We'll be talking about benign prostatic hypertrophy and its relation to some of the urinary systems and men's health next week. When we look at urethral strictures, okay, now we've moved from the ureters past the bladder, now to the outflow tract, okay, and look at urethral strictures. Let me get my page over. Okay, so what are the etiologies of some of these urethral strictures? Typically occurs more in men than women. More in men than women. STDs are typically the major cause of urethral strictures. Any guesses of what disease most common? It's okay. Gonorrhea is typically the biggest problem that we see. Other causes can be trauma to the urethra, can be from catheterization. That's why we tell you never force it, okay, because you can cause trauma. You can also get trauma from urological procedures, and you can also get trauma from childbirth. We also see some trauma from motor vehicle crashes as well. Clinical manifestations of urethral strictures, what do you think it would be? So that you got the urethra, it's stricted down, so what's going to happen to the urine flow? It's going to be decreased going out because you've got now that bladder's got to work harder to overcome that stricture in there, so you're going to have a decreased flow of urine. Because of that decreased flow, we get stasis of urine back up in the bladder. And because of that stasis of urine in the bladder, what can that lead to? I hear lots of mumbling because you're not sure, right? Urinary tract infections. Anytime you've got urinary stasis in the bladder, you increase the risk of urinary tract infections. It can lead to something called overflow incontinence, where basically the bladder fills and fills and fills, and finally the pressure is so in the bladder that the patient can't control it, and they just involuntarily urinate on themselves because of that overflow type process. Now, what are some of the complications? One of the big things is that lack of flow through there in the urinary tract infections. But one of the big things that can happen is the fact that because of that decreased flow, that bladder begins to hypertrophy. It gets larger. The musculature has to get stronger to force the urine past that stricture. So as that begins to occur, that muscles kind of continues to grow. And like all muscles, there's a point at which if it stretches too far, it can't collapse back down and do the job. So you can get hypertrophy and then get a decreased contractility of that bladder. The other thing that can happen, the way that bladder and the smooth tissue and the muscle tissue work together, you can get outpouchings of that bladder through the muscle tissues and get a diverticulum of the bladder. Now you've got urine up there stuck in those outpouchings, so it increases your risk of infections even more on those patients. That increase in that cystitis and infection there increases the risk of pyelonephritis for the kidneys. Treatment basically is to relieve that stricture. In many cases, they'll actually just go in and use what they call sounds, which are just dilators to go in and dilate that area. That is a temporary fix, and many people choose to go ever so often and have that done. Now, unfortunately, what you can do is you can create more scar tissue and make it worse over time. The gold standard is actually surgical removal of that stricture, and how long they take and before would they do it is going to depend on the amount of stricture and the length of the stricture that's going on. So, but many times they're just going to have to go in there surgically and repair that area. So that's the big treatment overall. Unfortunately, even with surgical treatment of those strictures, reoccurrence is very high in these patients. So these strictures tend to be a lifelong type problem once a patient gets it. Well, I almost made it to 1:30, didn't I? What kind of questions do you have? Say again? The urinary strictures, there is like one paragraph, and it is on page 1479. A lot of this didn't actually come from your textbook because your textbook has very little on urethral strictures. So I had to dig and find. Okay. Any other questions? All right. If you're willing to help me with this testing thing, if you'll come on down, I'll have you sign on the back of one of these, and then I'll give it to Dr. Miller. Thank you, ladies and gentlemen.